Good afternoon, everyone, and welcome again to the COVID-19 in Children seminar series. My name is Roshni Matthew. I'm a pediatric infectious disease physician, and I co-chair this with Dr. Alan Schroeder. And today we have an exciting session on COVID-19 and global health. And Dr. Schroeder will introduce our guests in a few minutes. Next week, we will have a session on COVID-19 and role of telehealth and clinical informatics. Thereafter, we will be going to monthly cadence. So we've had the wonderful pleasure of doing this weekly for 5 months, and we've covered a lot of topics. It has been extremely valuable to me personally, and we hope to the audience as well. But thankfully, things are maybe quietening down. So we figured we could move this to a monthly session, and we will keep you all posted on the date of the next one after the 25th. For the CME credit, the text code is on the slide here. And the other feature is the subtitles that you are seeing. If that is distracting, you can use the live transcript button at the bottom of the screen and then hide subtitles. We will start today with a evidence review by a trainee. And it is our pleasure to welcome Dr. Rachel Herdez today. She is a second-year fellow in pediatrics gastroenterology here at Stanford. She did her peds residency and chief residency year at Louisiana State University in New Orleans. And she's concentrating on nutrition, and her current research interests are obesity and adolescent bariatric medicine, intestinal rehabilitation, and medical education. Welcome, Rachel, and you can go ahead.
Thank you so much. Let me just share my, all right. Thank you so much. I appreciate that. So I'm going to go very quickly over an article that just came out at the beginning of this month in the Journal of Reproductive Immunology. And I chose this article because I thought it was very relevant to today's topic in the developing world. And I know that there's a lot of information coming out recently about what it means to have COVID-19 infection during pregnancy. And so the article we'll be talking about today is called The Longitudinal Analysis of Antibody Response Following a COVID Infection During Pregnancy. And this is a paper that came out of Italy. So the background for this paper was that we know most individuals will develop immunoglobulins within 1 to 2 weeks of symptom onset. And what they've been seeing is that the magnitude of the titer peak depends on the severity of the disease, and that's been observational over the past year. And what they also have found is that the anti-surface spike protein is that titer tends to correlate with neutralization of COVID-19. But what is unknown currently is the body's maternal antibody response and the longevity of the titers during pregnancy. So that was the purpose of this study. They had two main aims. Their primary aim was to evaluate the maternal antibody response during the first trimester when the mom got a COVID-19 infection during the first 12 weeks of pregnancy, and then watch that antibody response during her pregnancy. And then the secondary outcome or aim of the study was to look at the transplacental antibody transfer to the neonate. So their methods were that they selected patients between April and June of 2020 in the clinics at Italy. These were not hospitalized patients. I do want to stress that these were all outpatient patients who were in their first trimester and tested positive for COVID-19 infection, whether that was a nasopharyngeal swab or they tested positive for antibodies. And what they collected on these patients were titers related to the spike proteins, which are, as we mentioned, the neutralizing antibodies. And then they also collected antibody titers against the N protein or the neocapsid protein, or nucleocapsid protein, which is a non-neutralizing antibody. And they collected these titers from the mom at the first visit, which was her 12-week gestation visit during the first trimester, also at 16 weeks, 21 weeks, and then at delivery. And then they also collected the same titers from the infant cord blood at delivery. And so over the course of those 2 months, they screened 164 women, and they found that 17 were positive for COVID-19. Of the 17, 3 of them were asymptomatic, and the rest of them had very mild symptoms. And you can see them listed here, ranging from fever to cough and mild dyspnea. They did mention in their study that none of them had severe symptoms requiring hospitalization. All of them had mild symptoms. So of those 17 patients that tested positive for COVID-19, either from an RT-PCR, from a nasopharyngeal swab, or from antibody testing, they found that one person ended up not having any antibody titers at all over the course of her pregnancy. And then 16 of the 17 had antibody titers against the non-neutralizing antibodies, which is the capsid protein. And 9 of the 17 had positive antibody titers against the neutralizing antibodies, or the spike protein. What they found as their secondary outcome was that all newborns of women who developed IG antibodies during their pregnancies showed the same presence of those antibodies in the cord blood, and all patients, all neonates tested negative for COVID-19 at birth. I put these numbers here at the bottom to tell you the titers, but I think what's more helpful is looking at this chart. And so what this graph is looking at maternal this is the neutralizing antibodies against the surface protein. And you can see that of those, the gray lines represent individuals that tested positive for these titers, and the red is the mean over the pregnancy of all of the patients that tested positive. And you can see that over the course of the pregnancy, I think what's most interesting about this paper and what they'll talk about in the conclusions is that the neutralizing antibodies against the surface protein stays stable throughout pregnancy, if not increasing a little bit. And you can see here from this number at the bottom that the moms on average ended with 53, and this is just like an arbitrary number of measurement, but the neonates ended around the 58 range. And so you can see that it passed on to the neonates. What's also interesting from the study is that this graph represents the non-neutralizing antibodies, or the antibodies against the capsid protein. And you can see that over the course of this pregnancy, the average, which is the blue line, decreases over time. And while neonates also had positive antibodies in the cord blood, that number was fairly low in value, as you can see, 8 and 6 compared to where they started at 19. So what conclusions did they make from the study? They said that essentially only 52% of the women that tested positive for COVID-19 actually ended up having neutralizing antibodies. And what they are taking from that is that when they look back at the symptoms, like I mentioned, all of the patients were either asymptomatic or had very mild symptoms. And so that sort of goes along with the thought over the other studies and observationally that non-neutralizing antibody response correlates with infection severity. And so it may be that not every woman had not neutralizing antibody response because they had very mild infections. They also showed that neutralizing antibodies remained stable throughout pregnancies while non-neutralizing antibodies progressively declined. And then they show that there is a transplacental passage of antibodies to newborns with a first trimester infection in the mom. So what does this mean for us, and what discussion can come from this study? Obviously, it's a limited study in that it only included 17 women, but it does tell us that we should be cautious about just grabbing titers and be more specific about the type of titers that we grab, and that the evaluation of the type of antibodies during pregnancy is very important. It also hints that vaccination during the first trimester could be sufficient to provide adequate protection throughout gestation, as you saw that those neutralizing antibodies stayed relatively stable throughout the course of the gestation. And then finally, it hints at the possibility that pregnant women who have seroconversion to non-neutralizing antibodies, but not neutralizing antibodies against the surface protein, should be considered for vaccination. That's it.
Alan, you're muted.
Rookie mistake, man. Part of it is my computer. I apologize to everybody. My computer is making an unnerving buzz. So I'll be quick, but thank you, Dr. Hurtis. And if people have comments or questions about that article, you can put them in the Q&A, and maybe Rachel, you can try to answer them there. But we'll move on to our topic for today, which is global health. We've talked a lot about sort of US data prior to this, but obviously really important and interesting findings from low and middle income countries. And we have two of my colleagues from the Division of Hospital Medicine, as well as my friends that are going to be speaking today, real experts in global health, and very grateful that they're sharing their perspective with us today. The first speaker will be Dr. Rishi Mediratta, who's a clinical assistant professor in pediatrics at the Division of Hospital Medicine here. I've known Rishi since he was an intern, and he has been fun to watch him evolve into such an influential scholar in global health. He has two master's degrees, one in medical anthropology and the other in public health. He's been doing a lot of impressive work in Ethiopia over the course of his career, even predating residency, and now has really started to focus on neonatal mortality and how educational efforts can potentially impact neonatal mortality in developing countries. He also the undergraduate and graduate students here at Stanford, focusing on the medical and societal implications of the COVID pandemic. So great to have you, Rishi. Our second guest is Dr. Vicky Ward, also in the Division of Pediatric Hospital Medicine, where she is a clinical assistant professor, was like Dr. Mediratta, was a resident here, but also did a pediatric hospital medicine fellowship. She's wears so many different hats. It's almost impossible to keep track of all of them, but has been working, partnering with the Gates Foundation and leading a number of efforts in the Bihar, India region. She's actually just published, I think, 7 or 8 articles on their incredible work there in the recent edition of the Journal of Global Health. She also serves as a medical director with Dr. Charles Prober for Digital Medic, which creates and disseminates high quality educational curricula for healthcare workers in low resource settings. Additionally, she's done incredible work increasing awareness and efforts to get data on human trafficking and help to build the Stanford Human Trafficking Data Lab. So thank you guys so much for joining us. I'll let you take it away from here and stop the incessant buzzing.
Great. Thank you so much, Alan and Rashni, for the invitation. So we're excited to share our perspective on COVID in children, particularly a global lens and children from low and middle income countries. So today we'll focus a broad overview on a lot of topics in terms of the burden of COVID, particularly in children in terms of data that we know, impacts on routine care, the socioeconomic impacts, how COVID affects health education globally, vaccine equity, and then lessons learned, particularly from LMICs. I'm going to start the discussion focused on the current state of COVID in children in low and middle income countries. So first off, the global burden of COVID, as we all know, varies. But I think what's more interesting is, to what extent does it vary? How does it vary? And what are the countries that are not reporting data? So this is data from last week, taken from the Open World and data about basically the proportion of COVID tests that are positive. You can see countries with a darker color, like Australia, kind of a lower proportion positivity rate. But also you can see, the countries, particularly in sub-Saharan Africa, Latin America, where, more than 10 or 20% of tests are positive for COVID. So I think that's the first step to realize. Second is you can look at the countries where there's no data. And I think that's particularly revealing in terms of, it's hard to understand the magnitude of COVID, particularly in low and middle income countries, when countries are not reporting data. So in order to understand the positivity rate, we also have to understand the testing, how frequent countries are testing for SARS-CoV-2. So this slide shows the total COVID tests per 1,000 people. This is data updated a few days ago. So it's interesting to know that countries like the U.S., Australia, parts of Russia having more tests, upwards of 500 to 1,000 tests per 1,000 people, but also looking at sub-Saharan Africa, Latin America, where we're not seeing the testing frequency as much as we would expect. And there are many reasons that could account for this, leadership, actual testing supplies, flow of data. But part of the challenge in understanding the magnitude of COVID in children is really there's a lack of data and data disaggregated by children. But this starts to help us understand really where the data is coming from and where it's not. To delve into this a little bit more, based on the Hopkins dashboard today, globally, there have been 110 million cases of COVID-19 since the start of the epidemic and 2.4 million deaths. The data about the number of children who have developed COVID-19 are not routinely aggregated at the country level. We do know that there are, among 188 countries that we have some data, only 42 countries are reporting data disaggregated by age and particularly for children. So we can have a small window into the pediatric burden, but largely we're missing the majority of countries, and particularly LMICs. We have to remember that the early narratives that children were largely spared from SARS-CoV-2 originated from data in China and Italy and other high-income countries. We know that the children account for a relatively low burden of COVID-19. There was a systematic review that estimated between 1% and 5% of all COVID cases are in children. And we know that children have more mild disease than adults. However, as the epidemic is progressing, children may be more affected by COVID-19 than this narrative suggests. And it depends on the country, the stage of the epidemic, and how vulnerable children are in particular settings. So to kind of capture, is the burden as low as we think? There was UNICEF has been taking the lead on a lot of this data, and they've collected data. This is data reported in July. This is COVID cases among children and adolescents less than 20 as a percentage of the total national reported cases. So you can see, on the countries ranging from Spain, 1% of total cases of COVID in children versus, all the way on the right in Paraguay above 20% of all COVID cases among children. So this is at least, shows the percentage. But another way to look at this data is to reorganize this by high income countries. On the left, there were 24 of those amongst where data is reported, and then 18 countries from low and middle income countries. And so you can see, focused on the low and middle income countries, there tends to be, a higher percentage of children affected by or testing positive for COVID in low and middle income countries in comparison to high income countries. And when the researchers summed all this data, they found that LMICs had about 10% of all children are testing positive for COVID, whereas in high income countries, it's slightly less, around 7%. So, which is to suggest that the burden of COVID may be slightly higher than this estimated of 1 to 5% from a global global prevalence. I think there's still a lot more questions that need to be answered, particularly when it comes to COVID in children. First, is it less likely that children are tested because their symptoms are milder than adults? Or is it that children are less likely to be exposed to SARS-CoV-2 because of all the social distancing measures and school closures that have been enacted since the beginning of the epidemic? Or is it something biologically? Is it that children are less likely to be exposed due to less biologic susceptibility, the fact that there are fewer ACE2 receptors in children, or that there may be cross-reactivity from other coronaviruses that children commonly get. So I think still there's a lot to understand about this, but and I know researchers are collecting a lot of this data. I wanted to highlight in particular Nepal. So Nepal, there were studies going in neonatal mortality at a hospital setting. So researchers were trying to understand what is the burden of neonatal mortality in a particular trial. And they found the trial was ongoing. And in the beginning of the epidemic in Nepal, researchers found that there was an increase in neonatal mortality and stillbirth rates in the particular trial that they looked at. So, and the signal was quite dramatic. They found that between January and May of last year in Nepal, there was a 52% increase in institutional, 52% decrease in institutional deliveries. The stillbirth rate increased from 14 per thousand live births to 21 per thousand births. And neonatal mortality increased from 13 per thousand births to almost 3 times as high at 41 per thousand live births. They also found that the intrapartum fetal heart rate monitoring and breastfeeding within 1 hour of birth also decreased. And there are many reasons to account for this, partly a lack of demand, challenges in accessing healthcare, and also mothers were arriving to the hospital late, often in obstructed labor. And many of the women were having complications, including preterm birth. So the impact of the epidemic, particularly in Nepal, I think is just emblematic of what's going on globally, but really to show that neonatal mortality and perinatal mortality is particularly affected by that. When we look at, we know that children are less likely to die from COVID than adults. However, when you take a deeper dive into the pediatric mortality of COVID, we know that, and what we're finding is that there's a large variation between high-income countries and low and middle-income countries. There was a recent systematic review that looked at the reports of pediatric COVID deaths globally, and there were 3,788 pediatric deaths that were reported in a particular study. The researchers found that 92% of these deaths occurred in LMICs, whereas the remaining 8% occurring in high-income countries. The researchers further looked at adjusted for the population when it comes to COVID mortality in children. They found that in high-income countries, there were approximately 18 pediatric ICU admissions per million children in high-income countries, and 1.5 ICU admissions of a child with COVID per million individuals in a low and middle-income country. So that shows that their children are being hospitalized in high-income countries much more than in low and middle-income countries. But I think the striking figure is the fact that the deaths from COVID, when you adjust from a population, there were approximately 1.3 pediatric COVID deaths per million children in high-income countries, and almost double that, 2.8 children per million children dying from COVID in high and low and middle-income countries. So part of this may suggest that there may be a larger impact of pediatric COVID fatality in low and middle-income countries in comparison to high-income countries, in part maybe because of the challenges of providing pediatric critical care in these settings. So when I think about the impact of COVID on children, I think about this in 2 main categories. I think there are direct effects from COVID, and we looking at the morbidity and mortality. While these are important and still are ongoing, I think in comparison to the indirect effects, I think these indirect effects are probably more widespread and more more major than in the direct effects from COVID. And I think that's what I want to spend a little bit of time looking at, are the indirect impacts of the pandemic on reproductive, maternal, neonatal, child health, poverty, nutrition, and education are particularly devastating. There was a quote from the World Health Organization in terms of managing epidemics, and from their playbook in 2018. And I think this is particularly relevant to look at. The quote goes, people, efforts, medical supplies all shift to respond to the emergency. This often leads to the neglect of basic and regular essential health services. People with health problems unrelated to the epidemic find it harder to get access to healthcare services. We've certainly seen that here in the United States, but it's also true in low and middle income countries. So in order to look at the indirect impact of the pandemic on maternal and child health, the first question is really, how much of the indirect impact is affecting women and children globally. So researchers tried to model this impact, and they looked at the coverage of health services as a function really from being driven by four main factors: the availability of health workers, the availability of supplies and equipment in a health setting, and both of those lead to a particular provision of a health service. Also, there's a demand for healthcare services and the access to healthcare services leading to a utilization. So researchers looked at, in a pandemic, what are the variations in the availability of services, the utilization of services, and how that potentially could affect the coverage of healthcare services, and how the changes in coverage may impact mortality. We know that, amidst the pandemic, there are healthcare workers, equipment, facilities have been reassigned to address the influx of patients with COVID. We also know that the restructuring of healthcare systems can result in the closure of peripheral healthcare facilities. And we know that from lessons from the Ebola virus epidemic in 2014. We're also seeing disruptions in the global pharmaceutical and medical supply because of COVID. So the interesting finding is really, to what extent are these changes in healthcare service coverage related to excess death? And what I think the actual predictions are not as important to talk about, but just that a decrease in coverage of maternal and child healthcare services, along with reduced access to food, leading to wasting and malnutrition, leads to excess maternal and child deaths. And that all maternal and child healthcare interventions are not disrupted equally in a particular pandemic. The researchers further looked at and divided maternal health and neonatal health interventions. And they found that there were 4 respective interventions that would save excess death. The researchers found that IV uterotonics like oxytocin, IV antibiotics, IV anticonvulsants, and a clean birth environment would save up to 60% of additional maternal deaths. From a neonatal and child health perspective, minimizing the wasting prevalence, the case management of neonatal sepsis or pneumonia, oral antibiotics for pneumonia, and oral rehydration for diarrhea would save 41% of additional child deaths. So this goes to show that sustaining the healthcare system in a pandemic is essential to saving maternal and child health lives. Now, what has happened what happens in pandemics, and we can take from and learn from the Ebola epidemic in West Africa in 2014. We know that the childhood vaccination rates decreased in the pandemic, in the epidemic in Ebola. They found that there is an already low coverage of measles vaccines and at least 3 doses of the pentavalent vaccine of DTP, hepatitis B, and Hib. And after the Ebola epidemic, the coverage decreased even more. Further going into Ebola, the healthcare utilization decreased by 18%. And declines in the utilization were greater for inpatient care and for deliveries than for outpatient care. Researchers also, and we found that the Ebola epidemic disrupts health systems. There was a negative impact on the healthcare workforce, leadership and governance, as well as a disruption of health programs and systems. We know that there was high preventable all-cause mortality that was identified, and as well as a rise in teenage pregnancy, partly due to the lack of reproductive health services that were provided. So we know that, at least from the Ebola perspective, that when there's an epidemic or a pandemic, routine healthcare services are disrupted. So the question is, what's going on and what has happened, particularly in this COVID pandemic? So these slides are borrowed from colleagues at UNICEF that I've been in touch with. And UNICEF has taken the lead in surveying countries globally, asking them, what is the impact of the pandemic in your country in terms of healthcare services? So UNICEF presented and surveyed countries. This was in the third quarter of last year, so kind of fall of last year. They asked countries to respond to the coverage and the access of healthcare services in comparison to the prior year, pre-COVID, from a variety of different services and data sources. And they had a large portion of countries, 158 program countries respond to this survey from them. Their total sample was 141 countries. And this slide shows the global disruption of healthcare services by the particular healthcare service in all countries. So the y-axis looks at the percent decrease in a particular healthcare coverage, and the x-axis is looking at family planning services, the health campaigns for vaccinations, healthcare for displaced and refugee populations, maternal health, up to newborn and even mental and psychosocial services. So you can see that in moderate to severe disruptions, and moderate is defined as 10 to 49% decrease, and severe being greater than 50% decrease in the particular coverage. You can see that health campaigns for vaccinations have had 12% of countries are reporting severe disruptions in campaigns, as well as outpatient care for childhood infectious diseases, almost 30% reporting moderate reductions in outpatient services. So we're seeing countries reporting, routine vaccination is disrupted, outpatient care is disrupted, maternal health care services disrupted, as well as health campaigns. And I think this is an important window to understand, wow, what is the impact of healthcare services globally? And at least this is just in terms of coverage. We haven't quite figured out how that coverage has led to health outcomes, but at least this shows countries are reporting mass disruptions in services. I wanted to briefly highlight the role of these disruptions in humanitarian crises. We know that countries experiencing humanitarian crises are more fragile and particularly more vulnerable. Crises threaten the health and safety of communities directly and through the destruction of existing health services and infrastructure, with pregnant women, newborns especially vulnerable. So UNICEF, in their survey, looked at humanitarian action for children, which is in what their abbreviation was as HAC, H-A-C. And HAC represent countries in humanitarian crises. So when UNICEF surveyed these countries, they were comparing countries experiencing humanitarian crisis in comparison to the rest. And they found that among these disruptions in healthcare across the board, countries experiencing humanitarian crises are more likely to have even more disruptions in comparison to all other low and middle income countries. So in almost, the severe disruption is almost twice as more in countries experiencing humanitarian crisis. So it's another level that children living in these humanitarian crises are particularly at risk and vulnerable. What I find is interesting is what countries are reporting as what are the reasons why healthcare services are disrupted. Countries reported 27% said that there's a reduction in demand due to fear of infection. I think we can all relate to that. It's even true in our practice here. 19% of countries reported lockdown restricts users' mobility and transportation. 11% said that there was a closure of facilities and services or a postponement of services. Inadequate PPE, 8%, personnel gaps, and you can see the rest. And so looking at it's really there was a fear of infection and challenges of accessing healthcare and getting to the health facility as reasons to explain these decreases. I want to move on to the impact of COVID, not only on healthcare services, but also on poverty. We know that in developing countries, children and living in monetary poor households are at risk. And we're finding that there is a dramatic increase in the number of children living in households with monetary poor households. Pre-COVID, there were UNICEF estimated 582 million children living in monetary poor households. That number is expected to increase to 715 million, so almost 142 million excess children, and expected to minimize that risk this year. But children are living in monetary poor households, and that impacts their health, impacts their education, impacts their nutrition. Another metric is to characterize multidimensional poverty. And multidimensional poverty is a summative measure of inadequate health, inadequate education, as well as inadequate living standards. Pre-COVID, 47% of children were characterized in multidimensional poverty, and that is expected to increase to 56% due to the pandemic. And that would mean 150 more million children living in multidimensional poverty. Briefly highlighting nutrition. So we know that globally in crises, on a baseline, there are already millions of individuals who are acutely food insecure or directly at risk of becoming food insecure due to the pandemic. And we know that, or at least that the estimated increase in wasting, moderate or severe wasting in low and middle income countries is expected to increase by 14% from COVID, and in large part due to the loss in gross national income per capita. We know that there's mass unemployment, and that affects households' ability to obtain food, and in these food crisis locations, there we see an increase in wasting, and this increase in 14% of wasting due to the pandemic translates to an estimated 6.7 million individuals, more children with wasting in 2020 in comparison to 2019. I want to also link nutrition and education. We know that in many parts of the world, the most reliable meal that children will have is actually at school. And with disruptions in education, schools being closed due to the pandemic from social distancing measures, there are an estimated 267 million children missing out on meals at school globally. And so this is it's a crisis that is only anticipated to get worse depending on the scale of school closures within each country. The last point I'll mention is directly on education, and we all can identify with how children have been impacted from not being in school. UNICEF estimates that there are 1.5 billion children who were disrupted in their school. Now, I think what's more interesting to talk about is that that there are digital platforms, internet, radio, and TV as forms of information that is distributed to children about education. So we know that the internet, there are challenges in internet globally, but there are, amidst these 1.5 billion children, there were 463 million children who potentially cannot be reached from these digital and broadcast remote learning platforms. And so that means there, 31% of the children who, could not go to school had no means of learning, learning about their learnings from internet, from radio, and from TV. And the vast majority of these children who could not be reached by digital and remote learning platforms occur in Africa and Southeast Asia. And when you take a further deep dive into this, it's children living, 3 out of the 4 children who cannot be reached are living in rural areas and poor households, and the vast majority of these children are preschool or pre-elementary children. So we've briefly summarized the state of COVID in terms of their direct impacts on children, as well as the indirect impacts on healthcare services, education, poverty, and nutrition. And now I wanted to turn it over to Vicky to share what can we do from an intervention perspective.
Thanks, Rishi. I think as we look at, we can go to the next slide. As we think about the impact of COVID on children in low resource settings, we really have to think about the magnitude of the issues that we're facing. And I think we wanted to spend some time today talking about interventions, both as sort of a way to think about how we can start to address the pandemic in these settings, but also really think about how we allocate resources accordingly. So when we think about health systems that are particularly fragile as they are in low resource settings, we can start to understand why some of those numbers that Rishi was talking about are occurring. So the review that he mentioned that was published by Taito Kitano from Sick Kids just a couple of weeks ago, that showed when they reviewed all of the reported pediatric deaths, that over 90% of them occurred in low and middle income countries, compared to less than 10% in high income countries. If we think about how are we going to address the COVID pandemic for children, we really need to focus on these low resource settings. Now, the reason why, as he alluded to, is mostly because of health system capacity. So there's variable ability to provide acute and intensive care services. This is a problem really of limited resources. So particularly sort of when we think just about prevention, there's limited availability of PPE. There may not even be hand sanitizers or regular sort of public availability of clean water and soap. So that's one issue. The second issue is that if people do get sick, if children are getting sick, there's limited respiratory support. So variable access to oxygen, particularly in rural settings, there's rare access to oxygen, and certainly rare access to positive pressure ventilation if it's needed. Only a few ventilators may be available in only urban settings and academic centers at that. And even CPAP can be rarely available. So that is sort of the piece of how we provide supportive care can be a real challenge in low resource settings. When we think about therapeutics, access to monoclonal antibodies is limited, both because of limited sort of availability, although Gates Foundation and Eli Lilly have tried to partner for increased distribution. Even so, there are still challenges with storage and distribution. And then diagnostics and therapeutics, as Rishi was mentioning, there may be limited access to diagnostics. But if we think about how we're going to make sure that we're identifying the kids who need the most help, there can be a real limitation there. And then in terms of sort of how we manage some of the complications like MIS-C, which we have seen more of here, really, I think the question there is diagnostics and therapeutics for MIS-C are also limited, particularly things like echoes and IVIG really may not be access to that sort of throughout the country. So I think knowing that and then put in context of, while there's been quite a lot of success in places like sub-Saharan Africa in terms of sort of early lockdowns and public health messaging for prevention, There's a real risk of resurgence when those lockdowns are lifted and if we don't have good access to or distribution of the vaccines. So knowing that, I think then the question becomes, how can we strengthen health systems so that there's optimization of available resources and making sure that knowing that the success is really going to be coming from building transnational partnerships and support from multinational organizations. So this is one of the sort of main platforms to provide that. It's the WHO's Access to COVID-19 Tools, which is the ACT platform. And the next slide, thanks. The ACT platform is really a $6 billion commitment from multinational organizations to support COVID diagnostics and therapeutics. So you have the Global Fund supporting high quality rapid tests, you have therapeutics coming from Wellcome Trust and UnitAid, and then you have purchasing and distribution of 2 billion doses of vaccine by Gavi and the Coalition for Epidemic Preparedness, and I'll talk a little bit about that later. Then you start to see transcontinental partnerships that are really sort of buoying up health systems. So Africa's CDC, the African Union, really have come together to create what they call PACT, which is a collaboration to increase testing. So they have purchased 90 million tests to make sure that they have better testing capacity across countries, and implemented a sophisticated contact tracing mechanism to make sure that they're tracing all of the cases. And then you have a platform, a partnership, which is called the African Medical Support Partnership. And what they want to do is create opportunity to buy PPE and other products in bulk so that the purchase price is lower. So you see these collaborations really coming together to optimize resources and to create more cost-effective solutions. So we'll talk a little bit about COVAX. You may have heard about this in the news or in some of the recent reports that have come out. But COVAX, which is the COVID Vaccine Global Access Initiative, is a multinational alliance that's led by WHO, Gavi, and the Coalition for Epidemic Preparedness, really focusing on equitable access and distribution of vaccines. The goal here, as I mentioned, is to distribute 2 billion vaccine doses for 92 low-income countries. And some of the main tenets are equity and transparency. I think knowing sort of the issues that are coming down the pike, this has been an important focus. So COVAX really coordinates the logistical infrastructure, the financing, training, and resources that are going to be required for vaccine distribution. And the goal is to sort of counter vaccine nationalism. So typically countries will bid for vaccines, enter into a bilateral agreement with pharma companies and purchase the vaccines for their citizens. In low resource settings with less purchasing power, with fewer resources, these are the areas where you're going to have highest risk of inadequate supply. And so really making sure that we're thinking ahead about how do you enable and create distribution of vaccines in an equitable fashion is going to be really important. Next slide. So one of the keys here have been transparency around vaccine equity. So the WHO has created a values framework for the allocation and prioritization of COVID vaccines. And this is going to be critical. As we know here at Stanford, if we don't really focus on equity and making sure that we're prioritizing the highest risk groups, we're going to have trouble down the line. And so this has been a key tenet for the COVAX platform. The vaccine distribution framework that they've created includes human well-being, equal respect, global equity, next slide, national equity, reciprocity, and legitimacy. So really, I think having that as a framework and a benchmark to make sure that we have vaccine equity will be really critical. Next slide. They've been really articulate about sort of who are the highest risk groups, remembering that this is going to be prioritized for 20% of populations. They have to be very clear about who should be receiving these vaccine doses. So phase 1 will sort of be similar to what we've done here in the US, where healthcare workers, older adults, and those with serious health conditions are prioritized. But then also making sure that countries that are highest risk of transmission, those who have the most vulnerable healthcare systems, so the fragility of healthcare systems that we spoke about before is really important, and those with highly vulnerable populations, so particularly those in conflict settings, is a key priority. And then they have what's called a humanitarian buffer. So focusing on refugees, asylum seekers, and workers in those settings, really making sure that we're thinking about the populations that both have very high risk of transmission, but also may have extremely limited access to care if it's necessary. Next slide. So that's sort of the health system strengthening piece and the sort of multinational buoying up of the health system. Turning attention now to other interventions and really focusing on if we have limited access to resources, limited care if it's necessary, what can we do to sort of both encourage sort of all of the prevention activities that we know to be effective, and also to make sure that we're encouraging routine care, as Rishi mentioned, is really falling off after decades of work to try to expand and implement routine care mechanisms that we know are successful. They're all falling back, and really how do we make sure to get people sort of the care that they need when they need it. So we'll talk a little bit about prevention education, and this is work that we've done with Digital Medic with Charles Prober, as many of you know. And the idea here is really, when COVID was sort of emerging and we were learning quite a bit about what are the key prevention mechanisms, what do people know to keep from getting sick, a lot of that information was being put out in sort of tomes of advice from the WHO and the CDC. And the question became, how do we get this information out to massive populations of people who really need to know what those messages are in a way that is both accessible, but also will lead to behavior change. And so sort of building on the idea that education can spread quickly if messages are done well, the Digital Medic team put together multiple types of messages. And so we have to think, first of all, what kind of access will people have to data? So some places have regular, consistent Wi-Fi. Some people have smartphones, but a huge majority of population may only still have a flip phone or no phone at all for their educational materials. And so we had to sort of think about, how do we distribute educational messages quickly and in different formats. And so on the left, you can see poster and infographics, and really this is just sort of the standard putting a poster on the wall. But if you create it so that people can download it, print it, and then put it on their clinic walls or put it in their public places, you can reach a larger swath of the population. And then SMS and IVR messages. So for those people who only have flip phones, who may need to call into a service to get their educational information, which many people do, millions and millions of people do, we wanted to have educational content available. So creating sort of key messages that could be delivered through the phone, where people would call into a number and get those messages, has turned out to be really important. And that's work that we've done with Viamo. And then moving on to sort of the app-based smartphone education. So there is a good majority, estimated about 70% of people may have some access to a smartphone, whether it's their own or a family member's phone. And being able to look at those key messages through videos or through sort of infographics or GIFs, that has been a really important way that people have access information. Actually, a number of countries, specifically one is Malawi, where most people get their educational information for health from Facebook. So I think knowing that, we had to think about how could we get those messages to people. And then sort of moving along the spectrum to a full learning platform. So the emergency medicine group here, in partnership with Digital Medic, put together a COVID for Providers course, a sort of fully optimized course that helped people understand how to both prevent COVID, but really how to manage both the acute needs and the complications of the virus. Interestingly, that has provided a platform for people who are now implementing telehealth around the world to learn more about how to manage COVID. So one of our partners in Pakistan runs a sort of whole cadre of women doctors who do only telehealth for maternal and child health. And they really manage COVID for sort of all of those people who are in quarantine or being cared for at a community level. These telehealth providers will do their management via the internet. And they did the training through this Coursera class. And I think it sort of speaks to the fact that when there are limited resources, creating public goods that are accessible broadly can really create quite a bit of impact. Next slide. So thinking about then moving forward to sort of socioeconomic intervention. So as Rishi mentioned, a lot of the impacts of COVID are going to be on these sort of broader scale socioeconomic impacts of poor health and poverty and limited resources. So in a place where there may be limited internet access, can people still get the education and the information that they need? Or will they be limited because they don't have internet? So there has been a move to really expand internet access just for that purpose of making sure that people can access information. Cash transfer programs, we've had a lot of conversation in the US about cash transfer, but particularly in places where there's multi-level poverty, cash transfer has been some of the most important interventions, and we're studying now what the impacts of those cash transfer programs will be on the population level. And then food programs as sort of self-explanatory, that inadequate access to food is one of the key drivers of poor health right now, and it's particularly in the context where day laborers really only have enough money to access food for that day. If that becomes unavailable, then how will people access food? And so food programs are becoming increasingly important. Next slide. Thinking about educational interventions, there are multiple different types of educational interventions that have been created. But I think knowing that while here we can have kids on Zoom school, which has its own challenges, if kids don't have access to internet, cell phone, et cetera, what can we provide? And so, as Rishi mentioned, there's been radio and TV programs and things of that nature. Next slide. I'm going to speed through in these last 2 minutes. So I think the key that I just want to make sure is highlighted is that low resource settings, while having some challenges and barriers, have really a lot to teach us here in the US and in other high-income countries about how to manage pandemics well. And some of those lessons have come out of battling SARS-1 and MERS and Ebola. But really the key points are importance of just go back a little bit, one more. Early containment and prevention, making sure that early lockdowns occur. And a lot of people, a lot of countries had very early lockdowns with strict quarantine measures, and that really prevented quite a bit of transmission. And then leadership to create cross-border collaboration and make sure that there's good contact tracing. Centralizing public health messages and increased public health expenditures will be key for population health. And then focusing on population-wide socioeconomic support. And just to mention that greater use of outdoor space because of better ventilation has really been a key as well. Next slide. So key takeaways from what we've learned from low-income countries in the face of the COVID pandemic. Certainly many lessons to be learned from LMIC solutions. Collaboration is critical to make sure that there's equitable and sustainable successes. Huge networks of community health workers working together to create educational interventions that can be distributed to the public. All of those things are really creating significant public health change. As Rishi mentioned, we don't know what we don't know. And so without disaggregated data to focus on pediatric illness, we know that we're going to have limited information on the burden of disease. But we also know that the majority of COVID-related deaths in children are current and low resource settings. And so how can we create interventions and create sort of optimization of the resources that exist to support and to intervene? And then the importance of digital divide and contributing to inequity. If children are losing an entire year of school, what does that mean for the long-term trajectory of a population in terms of school education and future capacity? And we really need to focus on providing those socioeconomic supports so that we can make sure that the health of the communities is supported from a sort of multi-dimensional angles. And then really strengthening the health system to making sure that children are protected when they're faced with major disruptions like pandemics. So I apologize, we're right at time. I'm not sure if we have any time for questions, but thanks all for listening in and look forward to working together on solutions for low-income countries.
I think we will wrap it up. Drs. Ward and Mediratta, thank you guys. That was a really wonderful talk, and you guys are both doing great work. So thank you for teaching us today and highlighting the inequities in all of the issues relating to COVID in low and middle income countries. country. So thank you all for joining, and we will see you next Thursday.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.